Uh, Hello all. Today we're going to talk about pathological fractures. I myself, Dr. Senthil Narayanan, senior resident orthopedics in SLIMS. Okay. So as you can see in this picture, this fracture is not due to just trauma. There is something going on the proximal humerus. As you can see at the arrow pointed, there is some lysis and there's also some cortical destruction in the medial cortex until involving the metaphysis also. So, introduction. Pathological fractures are fractures occurring in abnormal weakened bone during normal activity or after minor trauma. Many of these patients have additional fractures, delayed union, or non-union. The causes of pathological fractures, as you can see, can be uh, put under correctable conditions and uncorrectable conditions. Correctable conditions include renal osteodystrophy, hyperparathyroidism, osteomalacia, and disease osteoporosis. Uncorrectable conditions include osteogenesis imperfecta, polyostotic fibrosis dysplasia, postmenopausal osteoporosis, Paget's disease, osteopetrosis. So, coming to demographics, it is a major health problem for 50% of the people more than 50 years. So, it mostly occurs in the people, older age people. And those people who are affected are osteoporosis women and the patients more than 50 years of age who sustain hip fracture. There's a study that says 20%, 24% will die within a year. One of every two women will have an osteoporosis related fracture in her lifetime. Spine, proximal femur, distal femur, proximal humerus, distal radius are the common locations for pathological fracture. So, more than 50% of the tumors can metastasize to skeleton. So, these pathological fractures are mostly due to metastasis or primary carcinoma. So, that more than the 50% of the carcinoma can metastasize to skeleton. These tumors mainly originate from breast, lung, prostate, thyroid, kidney, and the common sites of metastasis are spine, pelvis, ribs, skull, proximal femur, proximal humerus. So, how will you evaluate a patient with a lytic bone lesion? So, this table column is taken from Rockwood and Green. So, as you can see, first you have to ask the history, whether the patient has noticed any in the recent times has noticed any thyroid, breast, or prostate nodule. And you should also check the other symptoms, not only orthopedics. You should also be able to check for other symptoms like gastrointestinal symptoms, weight loss, blunt pain, hematuria. In physical examination, you have to look for any lymph node enlargement. You have to examine the thyroid, breast, lungs, abdomen, prostate, testicles, rectum. So, plain X-rays, you have to take plain X-ray of the chest and also the affected bone. The affected bone is taken in two views, AP and laterally. And technician 99 body scan can be used in selected cases such as lymphoma, where there is uptake radioactive material by actively proliferating cancerous tissue. So it is able to differentiate between infection or the acute stage itself. The technician magnet scan is useful to detect infection or any kind of lytic coagulation like cancerous tissue. The other one is CT scan with contrast. It's taken for chest, abdomen, and pelvis. In the laboratory, you should look for complete blood count, erythrocyte sedimentation rate, calcium phosphate, urine analysis, prostate-specific antigen, immunoelectrophoresis, and alkaline phosphatase. So finally, coming to needle uses, open biopsy. So you have to decide whether you go for needle biopsy or open biopsy. So this is how you evaluate a patient with a lytic bone lesion. First starting with the history and then physical examination, then all those investigations, then finally coming to the biopsy. Needle is just open. So factors suggesting a pathological fracture. What are the factors that suggest a pathological fracture? Uh, uh, when the patient has come into you with symptoms of spontaneous fracture, that patient has just had a mild trivial trauma. But the cause of trauma are not supposed to cause a fracture in a normal healthy individual, but it has caused a fracture in this patient. Fracture after minor trauma. Pain at the site before fracture. A patient will be having pain in the right proximal thigh for like 2 3 months, and suddenly you develop a fracture there. So you should ask about any history of pain before he had fracture. So there is multiple recent fracture. So history of multiple other fractures that he had gone for any surgeries or previous history of any biopsy and will also is useful. An unusual fracture pattern, that is banana fracture. Patient older than 45 years. And the history of primary malignancy. The patient has any history of thyroid cancer, prostate cancer, breast cancer. You should also take that history. So what is a banana fracture? Banana fracture is a transverse fracture after minor trauma to an abnormal area of the bone. It is a frequent pattern in pathological situations and has the appearance of breaking a segment of banana. So how will you evaluate plain radiographs? Question: where is the lesion? So epiphysis, it is metaphysis, this is diaphysis. So whether you have to look for whether lesion is in the epiphysis or in the metaphysis or in the diaphysis. Whether the lesion is in the cortex or the lesion is in the medullary canal. So you should also look for the site of the lesion, where it is whether in the long bones or in the flat bones. Then you should look for what is the lesion doing to the bone, whether it's causing a total bone destruction or diffuse or minimal bone destruction. Then what is the bone doing to the lesion, whether it is a well-defined reactive ring, intact but abundant periostral reaction that cannot keep up with the tumor growth, that is permanent triangles. The tumor just proliferates very fast that periosteal growth cannot keep up with the tumor. So there is a elevation of periosteum and that forms as a triangle-like structure in the junction of periosteum and the bone. It is permanent triangle. So in the well-defined reactive ring, that is slow-growing, it means a benign and slow-growing tumor. Intact but abundant periosteal reaction means aggressive tumor. Then there is a Korman triangle, it is suggested highly malignant. Korman triangle is seen osteosarcoma and Ewing sarcoma. What are the clues to this tissue type within the lesion? Okay, whether the lesion has any calcification means it has no bone infarct or complex tumor. When there is ossification, it means osteosarcoma or osteoclastic. When there is downwards appearance, it means fibrous dysplasia. This is an X-ray. I'm showing multiple lytic deposits in the spine of the patient. As you can see, all these vertebral bodies are involved. On the right side, you can see there is a fracture, isolated fracture of lesser trochanter. When there is isolated fracture of lesser trochanter, you should always suspect there is some lytic lesion or pathological fracture. That is the brain. So there is some osteoblastic deposits in the spine, the multiple areas of spine, and is also there is a L3 wedge compression fracture. That is a pathological fracture. What is impending pathological fracture? In Paris Murray in 1970 says that increasing pain with advanced cortical dissections of lesions involving more than 50% of the shaft diameter. That is, these patients are more supposed to have a pathological fracture in the future when they have the symptoms of increasing pain and also advanced advanced cortical restriction lesions involving more than 50% of the shaft diameter. Beals in 1971 says lesion more than 2.5 cm are at increased risk to fracture. And Fiedler in 1981 says 0 to 25% if the shaft is destroyed, the incidence of fracture is 0%. And there is 25 to 50% incidence is 3.7%. And 50 to 75% shaft is destroyed, the incidence is 61%. And more than 70% of shaft is destroyed, the incidence is 79%. So there's a Mirror's criteria for the fracture assessment risk. So it says when do you prophylactically operate the patient. So there's two variables. The score is given like 1, 2, 3. In the site, in upper extremity a score of 1, lower extremity a score of 2, and peritrochanteric region a score of 3. The pain, mild pain a score of 1, moderate a score of 2, severe pain a score of 3. Lesion. For mild lesions, score of 1 is plastic, 2 is mixed, 3 is lytic. The size less than 1/3 of the diameter of the bone, 1/3 to 2/3 diameter of the bone, more than 2/3 of the diameter of the bone. So each patient situation is assessed by assigning a number to each aspect of this presentation. Then adding the numbers to obtain the total number to indicate the patient's age for a fracture. Each patient whose total number is 7 or less can be observed, but those with a number of 8 or more should have a prophylactic interval fixation. So when is bracing indicated in a pathological fracture or impending pathological fracture? That is in limited life expectancies, in severe comorbidities, small lesions, radiosensitive tumors, humerus shaft, forearm, tibia. Weight bearing in these patients should be limited. And the old age patients has a limited life expectancy and they are not medically fit for surgery that you have to go for bracing. So coming to operative treatment, the guidelines that says that you should allow immediate weight bearing in this patient. Intramedullary device or modular prosthesis define stability. Following the tail method, activate is used to increase the strength of fixation. As you can see, these patients are already osteoporotic. The bone's quality is not good. There is some lysis going on the bone. So these implants will not have a good hold in the bone. So to have a good purchase or good stability, good strength, we use a bone cement. This polynickel ultrafiltrate. And the process is used in metastatic lesion. It should be cemented into the host bone. So prophylactically stabilize as much of the affected bone. These are the guidelines for operative treatment. So there are various options to treat pathological fractures. So in proximal humerus we go for total humeral endoprosthesis because it involves the joint. So you can't do a conventional plating or nailing because joint is destroyed. In the humerus shaft you can go for locked intramedullary nail with intercalary allograft. The distal humerus, which you can go for a flexible intramedullary bicondylar fixation of the plate. Also, you can go for the humerus involved in the joint. You go for a resection with the model or distal femur reconstruction. Radius ulna flexible locks, rigid plate fixation, radial head resection, and the curettage. So these are the X-rays. There is some. Mostly in this patient will have multiple myeloma. There is widespread lytic lesion in the proximal humerus. It has involved the entire humeral head, neck, and the proximal shaft. So they have resected the lesion and they have placed a proximal humerus endoprosthesis with a cement augmentation. So the X on the right side is a pathological fracture. It's mostly involving the shaft of the humerus while they were for intramedullary nail fixation. The first X-ray joint is involved, so they are not for endoprosthesis. The second X-ray shaft is involved, so like one for intramedullary nail fixation. So, so you should know when do you nail or when do you like in this patient they are done plating for the proximal members and the lesion has expanded and it started involving the entire bone. This patient you have to remove the plate and further you have to remove the entire humerus and reconstruct with some prosthesis. So there is a Harrington classification of periacetabular lesions from the lesions involving the acetabulum and the surrounding areas. Class 1 lesions are minor defects with the maintenance of the lateral cortex, superior wall, medial wall, which is treated with the conventional cemented acetabular component. Class 2 lesions are a major acetabular defect with the deficient medial wall and a superior bone, and it is treated with an anti-protrusion device or medial mesh. As you can see in this X-ray, there is involved the medial dome. The humeral head is long migrated medially, and it is treated with to prevent the even further protrusion of humeral head. They have done anti-protrusion device or medial mesh. In this X-ray, the lateral wall, superior wall, and medial wall is involved. They were done with the cemented acetabular component. Class 3 is massive defects with deficient lateral cortex and the superior bone. No substantial peripheral rim for fixation of metal component. Vestibular cage with long screw fixation into the remaining pubis, ilium, or ischium. Bone cement to provide stability and staying on pin to anchor the construct. There is no class 3 is a very massive defect and there is no the bone cortex available to for regular fixation of the metal component. So we should go for a separate vestibular cage with a very long screw fixation in the remaining part of the bone, that is pubis, ilium, or ischium. So this is used for class 3 defect. This is the acetabular cage. And as you can see in the right side we have gone for fixation through the ilium and also to the sacrum, part of the sacrum, and also to the pubis. Class 4 lesion, there is a pelvic discontinuity. What we use is saddle prosthesis or resection arthroplasty. We resect the entire acetabulum part of pubis and ilium and ischium, and, it's reconstructed with the saddle prosthesis, where it is articulating with the part of ilium. Proximal femur, the most common long femur is the most common long bone affected by metastasis, and it is most painful. The tip of fixation device should bypass a given lesion by at least twice the diameter of the femur. So this is the principle to prophylactically nail a femur fracture in a femur pathological fracture. So that tip of the nail should bypass a given lesion by at least twice the diameter of the femur. So in fracture involving femoral neck, what you do is cemented prosthesis is the procedure of choice. Curate all tumors in the tissue before putting the implant. Use a long stem component for adjacent lesions. Cement to be injected in a fairly liquid state after canal preparation. In fractures involving intertrochantericism, there is a high failure rate of DHS. So DHS are used only when there is a intact medial cortex in the intertrochanteric fracture. As you all know, in these pathological fractures will involve the lytic lesion plus a wide destruction of the medial cortex also, so DHS point for high failure rate. Intramedullary device is prosthetic replacement. The supramedullary device has an added function of protecting the femoral head. Cemented calca replacement prosthesis is used for more extensive lesions. The subtrochanteric region, you can go for a locked nail with a plus or minus bone cement to have additional fixation strength. And there is a failed internal fixation or extension destruction modular proximal fiber device is used. Increased risk of dislocation or abductor weakness with metaprosthesis. Bipolar head is used to provide additional stability if astragalon is not involved. Largest diameter nail is used for diaphysis. As you can see in this patient, there is a subtrochanteric pathological fracture. It has been operated and curated in sync for fracture, and the entire proximal femur has been resected and it's fixed with a modular prosthesis. So modular prosthesis and the cement. So the greater trochanteric piece is attached to there are some holes in the modular prosthesis where you can reattach the greater trochanter, lesser trochanter to provide some mobility in the picture. So as you can see, it will cause an abductor weakness in these patients. Fracture involved tumor diaphysis, it's traditionally you go for the static locked nail. You have to over 1 to 1.5 mm, largest possible diameter is used. Fractures non distal femur is difficult to treat due to poor bone stock and comminution. Lateral locking plate with cement or modular distal femur prosthesis is the treatment of choice. For extensive destruction, modular prosthesis is the choice as it allows an end block resection. Retrograde nail does not stabilize the neck, feeding into the knee joint. When you use retrograde nail, you can't stabilize the neck, and it also causes the sealing of the fascial tissue into the knee joint. So this is the X-ray. There's a pathological blastic lesion involving the proximal, that is proximal and distal femur, and it has been curated and cement augmentation followed by a lateral column plating. In tibia, the proximal tibia locking plate with a cement, and it involves diaphysis, you go for intraangulary nail. Pathological fracture in spine, and any cancer patient with a back pain, you should consider a metastasis. Any patient treated for osteoporotic compression fracture should undergo a biopsy when not responding to treatment or when there is excessive destruction of the bone. If CT guided biopsy, you can go for CT guided biopsy. When there is also multiple compression fracture, you should also look for any chance of metastasis involving the spine. In X-ray of spine, in the AP view, you can see there is a loss of pedicle on the AP view. It is called winking owl sign. As you can see, there is only one pedicle in the L4 area, and there is a destruction of the pedicle on the right side, and also lower part of L3 also there is some destruction. In MRI, there is a complete replacement of the vertical segment and multiple vertebral body lesions are present. Spherical involvement and it will have an intact vertebral disc. As you can see, there is some compression fracture involving the thoracic spine, and there is also widespread deposits in the vertebral joints. Important signals are seen. The treatment is for the spine pathological fractures radiation, corticosteroid for pain management, kyphoplasty, vertebroplasty, and adjuvant radiation. Indications for kyphoplasty is stable compression fracture with normal neurological function but persistent pain. Kyphoplasty, the patient should have an intact posterior cortex of the vertebral wall. Or else there will be complications of cement migration into the spinal canal. Indications of surgery. Progression of disease after radiation, neurological compromise caused by bone impingement, radio-resistant tumor within the spinal canal, impending fracture, spinal instability caused by pathological fracture, and there is progressive deformity. These are the indications of surgery in spinal pathological fractures. And this is an MRI of the pathological fracture a patient where they have gone for a curettage and they have gone for a stabilization and it's fixed within particle strut, particle strut graft. So metastatic lesions involving the scapula or clavicle are treated non-operatively. Large destructive lesions of the glenoid can be resected to relieve it. Scapuloplasty is a new technique where it alleviates scapular pain resulting from lung cancer metastasis. They are injecting cement into the lesion. It will cement will destroy that nerve endings inside the bone and will to relieve the pain. So it is a newer technique, scapuloplasty, more like kyphoplasty. Thank you. So that's all about pathological fractures. As you can so the very important things are Miral's criteria when you should operate and you should know how to evaluate a patient with the pathological fracture. Have a proper history and the X-rays and you should finally confirm with the diagnosis and the biopsy. There are biopsy, the post-biopsy you should look for whether the test is managed conservatively or operatively. So, thank you.